Hello, you are watching Medicine Today. Good to have you with us today. The topic of my show is prenatal test and diagnostic test part 2. For that I've invited again world-renowned prenatologist, that is maternal-fetal medicine specialist Dr. Gregory DeVore. Thank you, Dr. DeVore.
Thank you.
Dr. DeVore is born in the United States, and he received his college degree at Brigham Young University. His medical degree from University of Utah College of Medicine and residency in OB/GYN and the fellowship in maternal-fetal medicine at Yale University School of Medicine. He is board certified both in obstetrics and gynecology and maternal-fetal medicine. He is a clinical professor, Department of Obstetrics and Gynecology at David Geffen School of Medicine at UCLA. He is the director of fetal diagnostic centers in Pasadena, Tarzana, and Mission Hills, and he is also a director of perinatology at Providence Tarzana Medical Center. He has numerous publications. He has 128 peer reviews and 30 chapters for medical textbook. It's a great pleasure and honor to have you, Dr. DeVore.
Thank you.
Dr. DeVore came to my show in July, and he discussed the following at that time. And you can see that show on my website, and it's written there, medicinetoday.org. He discussed at that time pregnancy tests, prenatal labs, why we do those, causes of miscarriages first trimester, ultrasound in pregnancy, sex determination in early pregnancy by ultrasound or genetic testing, Nuchal Translucency and AFP, amniocentesis, 3D ultrasound pictures, and diabetes in pregnancy. Today, we are going to visit again the very important subject of antenatal or prenatal screening, and we'll be discussing also the hypertension in pregnancy, pretoxemia in pregnancy, NST and AFI, placenta previa, and he's going to show us a picture of a new technology where he's able to send his pictures to the patients through the iPhone or to their doctors. Okay, let's have the first algorithm about prenatal testing for Dr. DeVore to give us a general view of the tests we do in regards to screening, and then we go into details. If you don't mind, let's have the first one. Go ahead, Dr. DeVore.
Sure. What this is a guideline that if a patient, for example, asks the question, doctor, what technology can be used to guarantee me the safest pregnancy possible? This algorithm that I've developed would look at the fetus and also draw some blood from the mother in the first trimester of pregnancy, between 11 and 14 weeks. Then later in the second trimester, other testing would be offered to the patient. And then later after that, when the 20th week, additional testing would be offered. Each of the tests that are offered are specific for the time period and also address very specific questions about the health of the unborn child or predict the health of the mother.
Okay. I forgot to mention in my introduction that Dr. DeVore is married to Dorothy. He has 7 children and 14 grandchildren. Congratulations.
Thank you.
Okay. Let's go from the beginning. Patient is pregnant. We do the pregnancy test. She's doing fine. Now we're going to start the blood test. The first one we do, we say AFP1. Okay? And then at the same time, perinatologists do nuchal translucency. Okay? Would you mind explaining that? What's AFP?
Sure. Well, actually, AFP1 is terminology that's been used in the past. Now we call it first trimester screening. And the reason for that is because what is done in the first trimester traditionally, the fetus, which is about this size when we do the ultrasound, we measure the length of it. We also can measure the skin behind the neck. It's called the nuchal translucency. With that measurement, coupled with measurements of some hormones in the blood, we can predict or identify the fetus that's at higher risk for Down syndrome and several other chromosomal
We will come
abnormalities.
to nuchal translucency, but my point was not everybody does nuchal translucency for whatever reason, but let's go with AFP first one, and
Okay.
then some perinatologists do nuchal translucency. Why we
Okay.
do it? We show the picture about that.
Well, I think what you're referring to is that in the first trimester,
Yes.
the state of California offers or suggests either a serum test, a blood test only, be done,
Yes.
or a blood test coupled with what I call the nuchal translucency. Irrespective, the physician, the clinician, has to still measure the fetus to give an accurate gestational age so the test can be run properly.
Let's look the second picture, if we don't mind, about nuchal translucency. So as by showing the picture, you can explain more about that.
Yes, if you look at the picture, that would be the fetus lying on its back, and where that red line happens to be, it's called the nuchal translucency. That's the area behind the neck. That is measured with ultrasound, and if it's increased in size, the risk for Down syndrome, other chromosomal abnormalities, and heart defects could be present.
Let's have the other picture, which is the ultrasound of this. Go ahead, the next picture.
Yes, this is a picture showing what the nuchal translucency may look like on an ultrasound image.
Okay, back to the studio. Nuchal translucency, what it is, why it's sought, why you can see that, what's going on where the baby is developing something like that.
In the early development, the area behind the neck, the skin is separated by fluid. Now, it's because there's a system called the lymphatic system, which when fluid is in our tissues, the lymphatic system is like a vacuum cleaner. It cleans out the tissue or the fluid from the tissues. So this is going on in the development of the fetus. And this fluid, if it's increased, because it's not being cleared out as fast, when it's increased, that's a sign for a potential problem.
And it is increased for?
Well, it's increased. The associations when it's increased have been heart defects, serious heart defects, or chromosomal abnormalities such as Down syndrome or other chromosomal
Is that
defects.
something to do with the fetal circulation?
No, not necessarily. At one time we thought it was the circulatory
Yes.
problem. They believe the people who've researched this believe it's just simply the fluid drainage is not as adequate as it should be. So it shows up as an increased nuchal translucency.
Okay.
Sometimes in more severe cases, the area you saw in that picture is not only increased, but there's also increase in lymphatic areas in the abdomen or around the rest of the body where it's very severe, and that's called fetal hydrops.
Is there what we call false positive or false negative? If it is, please define what false
Sure.
positive, false negative means.
False positive is a scientific term that we use. I think for the person who's not a physician, what it simply means is if you do a test and the doctor tells you you have a risk for a condition, and often patients, when they hear this on a Friday afternoon, they don't sleep all weekend, then they go and have testing done that's more specific, and the test says, no, you don't have that condition, you're perfectly fine. That therefore is a false positive, meaning I told you that you probably had the condition, but other testing, which is more sophisticated, says, no, you don't have the problem. So it's called a false positive test. That occurs in about 5% of patients who have the screening process done. A false negative test is another scientific term that we use. But what that means is I tell you the screening test is normal. Things are fine, not to worry. But the baby is born with a problem, meaning the test did not recognize the problem with the pregnancy. It missed it. So screening is different than diagnostic test. Diagnostic test, you do a specific kind of a diagnostic test, you know the results are yes or no, absolute, no questions, no wondering. It's either there or it's not. Whereas a screening test tries to identify patients in the population and say your risk is higher or lower, but it's not a diagnostic test.
How much that has to do with how expert the ultrasonographer is?
The ultrasound component, now we talked about the first trimester test. I mentioned there was a blood test that could be done by itself or a blood test coupled with the ultrasound in the first trimester. The expertise of the ultrasound performer, the physician or the technician, is extremely important because if you don't measure it properly or you don't recognize other features in the fetus that could be significant, then you miss the opportunity to be helpful by finding problems that could be very relevant to the patient and the family.
Okay. All of us would like to have the best for our fetus or baby, but sometimes, for whatever reason, we cannot afford it or the insurance doesn't pay for it. They have to pay by law for AFP1, but not nuchal translucency. Is it true or no?
Yes, well, pardon me. By law, by California law, every patient should be offered either the first trimester blood test or the first trimester blood test plus the ultrasound. Now, the insurance companies, most all insurance companies that I'm aware of, will pay for either test. Some HMOs, however, have chosen not to tell the patient about the nuchal translucency. They say, well, we only cover the blood test. And we know that the blood test, while it's important, is not as good as the blood test plus the nuchal translucency in the first trimester of pregnancy.
I know. It is true, and some of us, we haven't used nuchal translucency because it's expensive, especially if they don't have insurance. Therefore, we have relied to the other tests, which will come to that. So the next test we do, after the first AFP, the second one comes between 15 and 18 weeks, which we call AFP2, or we give another name. Go ahead, Dr. DeVore.
Yeah. Excuse me a second.
The quad.
I got the cough. The second test that you mentioned is called the Quadtest.
Yes.
The Quadtest, again, measures 4 different hormones in the mother's blood. And if it's done in conjunction with a first trimester test, the state of California then analyzes the first trimester information coupled with the second trimester information and come up with a risk for detection of Down syndrome and other problems. So it's a blood test, again, done like the first trimester, but re-looking at the hormone levels in the second trimester.
Okay. One of the hard things for us as an obstetrician is when you do this, let's go to the blood, I'm not going to confuse AFP1 and AFP2, we get abnormal tests. And for us to explain to the patient, it takes a lot of time. Patient has to call, the mother calls, the in-laws will call, our family, we don't have any abnormal babies, this and that. And it's very troublesome. And I know from my experience that most of them, these positives, which are false positives, become normal. So what's your feeling about that? How to handle these situations like that?
Well, that is a difficult situation because when the physician, like yourself, calls the patient and says you're screened positive, that's the term that they use, the patients think automatically, my baby has a problem. And in reality, only a few times does the baby have a problem. But it's hard to explain that to the patient. So when the patient comes to our office, for example, or other offices, they undergo genetic counseling with a geneticist or genetic counselor. The counselor tries to explain really what the test results showed, what their risk is. Then they offer additional testing for the patient. That may be another blood test. Currently that's being offered. Or it may be an amniocentesis. Of course, it's always coupled with an ultrasound
I will
evaluation.
come to that. I like to take step by step so as the viewing audience is not confused. For us, it's easy, but for them, they may be confused. Okay, so we have the first and the second blood test. Now let's take the other thing. Blood test, AFP1, and nuchal translucency, and then second blood test. Now, one is 2 tests, the other is 3 tests. Now, how much a person is missing a diagnosis by not doing nuchal translucency, just doing the blood test alone versus all 3? Just give an example.
Okay, well, there are 2 things to consider. In the first trimester, if you just do the blood test, then there's no results given to the patient until after the second trimester blood test is done. And that combination of the 2 serum tests may find between 80 and 85% of the Down's fetuses that have a problem. It will miss 15 out of 100. If you do the first trimester blood test plus the nuchal translucency plus the second trimester blood test, there are 2 benefits. After the first trimester blood test and the nuchal translucency, the state of California will identify a certain number of pregnancies that are high risk for a problem, offer the patient genetic counseling and testing after 12 or 13, or at 12 weeks of the pregnancy. And then they have the second trimester test. Again, they will reevaluate that, and if it's positive, be offered counseling at that time as well. So the benefit is coupling the nuchal translucency and the blood test in the first trimester, the blood test in the second trimester. There are 2 opportunities to have further testing done that's more specific than simply waiting to the second trimester when you just have the 2 blood tests done.
Okay, now, so So you may detect a few more patients may have fetuses who may have a problem by doing the nuchal translucency, right? Now, you have then, we all like to have a patient to have what we call level 2 ultrasound, a genetic ultrasound. Now we add this to the genetic ultrasound to all these tests. Let's say AFP1, AFP2 genetic ultrasound, or nuchal translucency AFP1, AFP2, and genetic ultrasound. Is there much difference?
Yes.
Okay, go ahead.
I didn't mention, this is really important. Those of us who do the kind of ultrasound that I do, in the first trimester when we look at the nuchal translucency, some of us look at the fetal anatomy very carefully. And we have found in a study of over 7,000 fetuses in the first trimester that we're able to identify cardiac birth defects and other malformations as early as 11 or 12 weeks that otherwise would not have been detected till later in the pregnancy. So the nuchal translucency plus a detailed study of the anatomy in the first trimester is really now the current approach that those who are doing high-end ultrasound are using. In the second trimester, the genetic ultrasound that you referred to, that's another attempt to look at the anatomy and find birth defects that are unrelated to the screening process that we just mentioned. That may again include spinal cord defects, limb abnormalities, heart defects, abnormalities with the placenta, a lot of different things that are important to know about.
But the thing is probably detection is better at 20 weeks gestation, but the problem is that it's at late in pregnancy, right? Wouldn't you say that genetic ultrasound on level 2 at 20 weeks will detect more problems than you would have detected at 11 weeks when you did the
Sure.
That's what I'm trying to.
Yeah, and I think, but here's the thing to understand. If you never look, you never find. So in the first trimester, when you're doing your nuchal translucency examination, if you don't look at the rest of the fetus, you'll never find a problem. But if you do look and you find something, then you've helped that patient at that particular time, so you've found something that may have implications. In the second trimester, when you do the genetic ultrasound, you're still looking again. And if you find something, then it has implications. One of the most important things we do when we find certain types of birth defects, we know that if we deliver the patient at a proper facility and we have the surgeons available to take care of the problem, we help that unborn child in a dramatic way. It's life-saving if we have the information before birth.
Now, is it possible that there are some perinatologists, when they do nuchal translucency, they just look to the nuchal translucency part and forget about looking the heart? I don't know whether it is by law or by their profession. When they do that, they also have to look the heart and so forth. If you say a few things about that.
A very good question. There are certain perinatologists in this community that we live in who only do what they get paid for. Our philosophy at our practice is we do things more than what we get paid for because we believe in a complete care or a complete assessment. So I will, for example, do things that I don't get paid for, and that includes detailed anatomy in the first trimester. Many perinatologists that I'm aware of will simply say, I'm only getting paid to do the nuchal translucency. They come in, make a measurement, do the nuchal translucency. You're finished, you're gone, thank you very much. We believe in doing more because we can see more and we have the skill set to do so.
So some do like you, some don't do like you.
Yes, most of them don't do like I do, and some do. Let me just say this way. Some of my good friends do like I do, and some who are not so good, they do what they do.
Now, let's discuss ultrasound.
Okay.
There's level 1 ultrasound, level 2 ultrasound, then 3D ultrasound, and 4D ultrasound. The higher you go, the better it is. Go ahead.
No, well, okay.
Explain.
I'm going to explain. For years, it's been level 1, level 2. Some have said, well, what about level 3, level 5, level 10? The proper terminology today is as follows. The type of ultrasound done in the second and third trimester that should be routine is called the standard examination. That has certain criteria that have been defined by the American College of Obstetricians and Gynecologists and other organizations. Then there is what's called the focused exam or the targeted examination. That may be for a high risk for a heart defect. Then we have, built into those two, we have different tools that we use. Some use what's called grayscale ultrasound. It looks like a black and white picture. We have other tools that some choose to use, like I do, that looks at the heart and shows the heart beating with color, or has 3D ultrasound, or 40 ultrasounds.
Why don't we talk simple a little bit? Because as an OB-GYN, I'm really getting confused.
Okay,
Now,
okay.
let's go simple. The level 1 meaning that you just take the how old is the baby, this and dating, and so forth.
Okay,
Go ahead.
okay,
Go like
it's different.
that way.
It's different now.
Go like that.
Years ago, what Dr. Arsalani just said,
When I was young.
when he was younger, he's correct, there was a level 1 exam. That doesn't exist anymore in the real world of ultrasound at the level that we
Okay.
practice. It's no longer a term that we use. We called it the standard examination. However, the standard examination now has so many criteria that are supposed to be met that it's equal to the old level 2 exam that you were talking about.
Okay.
That it has many things that are supposed to be examined when you do a standard exam of the fetus. The problem today is the obstetricians, many of them, don't have a skill set to do the standard examination. It's gone to such a higher level that they say, I can't do that. I was never trained to do that. And so they're often referring patients to someone like myself to do the standard examination and just try to see more things.
That's the one that most of us will refer around 18 to 20 weeks.
Yes, that's correct.
Now,
That's the one.
Is there such thing where when you do ultrasound, the targeted ultrasound or level 2 ultrasound, let's say, where you, at 18 weeks you may miss something, at 20 weeks you may not miss something.
Yes.
Would you mind explaining the benefits of doing early or the bad thing doing early versus?
Yeah.
Go ahead, please.
The problem with ultrasound is you have to, like anything, if you have a dirty window, you can't see outside the car to see what's coming if you're driving. So the ultrasound is only as good as the image that is taken, and that depends on several things. One is the equipment that you use. Our equipment is very expensive. We have the very best. If you have a very inexpensive machine, then the picture quality, like a bad camera, will not be as good. Number two, if the patient is overweight, adipose tissue, I call it extra tissue, that's what I use, I say,
Okay.
extra, that dramatically
Soft
affects
tissue.
soft tissue.
Yeah.
Extra tissue, you know what I'm talking about, extra
Okay.
tissue. Extra tissue can interfere with the ability of the ultrasound machine to give you clear pictures. So we have to work with patients who have extra tissue to try and correct that. So when you talk about different time periods, the ideal time to get the best look at the fetus is 20 to 22 weeks. That's the best time.
The reason?
The reason because the fetus is large enough, the fetus is in the uterus at a certain position where the extra tissue doesn't get in the way as much. So there's a lot of things that go into having the best imaging. But again, it depends upon a lot of circumstances. So the tool that we use and the patient that we scan and the ability to see, they're all blended together to give us the best information we can have.
Now, let's say you do at 22 weeks, and unfortunately you find there's a defect in a baby where it's not viable or will be having a lot of surgeries later on, and then patient may decide to terminate pregnancy.
Okay.
In California, when there's a diagnosis of fetal anomaly, non-viable or whatever it is, how many weeks they have, they can say elective abortion?
Well, that's always a difficult situation. Termination of pregnancy by California law, if it's a law, is thought to be up to 24 weeks. That is a difficult time period for everybody because the patients that we see want to have their baby. They don't come to us because they don't want the pregnancy. They want the pregnancy. And so the problem that we always face is trying to give patients perspective as to what the problem is, how can we help, and there are different options. There are three options when you find a problem. One option is not continuing the pregnancy like you mentioned. A second option is to continue the pregnancy and the patient takes care of the child who may have a handicap depending on what it may be. The third option that we've often offered patients is one of adoption. And you'd be surprised at how many patients choose the latter option, adoption. We don't talk about that a lot.
Yeah, we don't.
And there are families who are absolutely happy to take care of those children, especially children with Down syndrome or even children with certain kinds of heart defects. There are families who welcome those children. So our role is not to ever tell the patient what she should do. It's to inform
They
them,
decide.
give them the choices and tell them the pros and cons and let them
Few
decide.
words about these 3Ds and 4Ds because we noticed that they opened a shop over in town. 3D picture for $50 or $100, and then they get up, it's like a souvenir. And later on you find out that that place was closed. I don't know why. Tell me something about
Yes.
those things.
We call that
souvenirs.
Yeah, we call it souvenir ultrasound. Here's the fad today. Here's what's going on, just to help your viewers know this. To open up a shop in a mall or any other place that's run to simply take pictures of 3D or 4D ultrasound is illegal. Why is it illegal? Because the people who are doing that are practicing medicine without a license. If I opened up a shop in my garage and did surgery, I would be thrown in jail. But because California and the regulatory people don't have enough people to do what they're supposed to be doing, these things have been allowed to occur. Now, the problem is, there's two problems. One is they expose the fetus to a lot of ultrasound energy. They scan for 5, 10, 15, 20, 30, 40, 50 minutes. It's a lot of ultrasound energy going into that fetus for no reason. You don't need that. Two, they mislead the patient and they let them believe that they've done a quality ultrasound when they're simply taking pictures to show them. We know of situations, I've seen this, where major problems have been missed, and the couple didn't know because they had a quote-unquote picture at the mall. The last thing that's happening today, it's very interesting, they call it, they have parties where the person will bring an ultrasound machine, a portable one, to the home of the patient, and it's called the gender reveal party, and they'll announce to everybody, oh, it's a boy or it's a girl. In the last month I've had 4 situations where the gender reveal party was told it was one thing and it was not, it was something else. And the trouble is, people go out and they spend money, they buy clothes for this little girl that turns out to be a boy, and this is something that's going on. So we really frown upon that type of use of ultrasound because number one, it's illegal, it shouldn't be done, and two, it has implications that people don't think about, and it's really not a good idea.
I do see patients who say, I had a very good obstetrician in this country. That's what do you mean very good? Every time I go over there, he does ultrasound on me. Every time. He's a great doctor. He's very meticulous. Of course, I have my feelings about that. I'd like to know your feelings about that, please.
Well, I think what you simply, I would divide it into 2 different groups, okay? Group 1 is if I were an obstetrician, I were doing prenatal care, and I wanted, and especially in the last part of the pregnancy when you come in, say, every 2 weeks, then every week, to put an ultrasound transducer on and look at the fluid and see what the baby's position and look at the heart rate is much quicker than doing the traditional type of care. But if I charge her for it every single time, oh, I'm looking at the fluid today. Oh, I'm looking at the baby today. We know from insurance companies, because we have this has been monitored, there have been cases where over 90 charges for ultrasound have been sent to the insurance company.
By one patient.
For one particular patient. And we know that there is an abuse in the OB community. If a patient goes in and has an ultrasound done every single time and the doctor generates a bill to the insurance company for that, unless you're very high risk and there's only a handful of situations that would require that degree of ultrasound, something's wrong.
I'd like to take a few more minutes, so I'd like to finish this topic. What do we know? At this time, we don't think ultrasound waves do any damage to the fetus. What do we know more about it? That maybe that 10 years from now they may say, whoever had so much ultrasound in the uterus and will have hearing problems. And because I know that when you put the transducer, baby starts moving the sound wave. Well, I like to know your feeling about that.
Yes and no. I mean, here's the thing. You don't know what happened or how much movement they have until you put the transducer on. So it's hard to say they were moving before. I mean, they do have movement. I think ultrasound, we know that millions and millions of fetuses have been examined with ultrasound. In Europe, and here's a good example. In Europe, in Germany, in France, and some of the other European countries, for years it was mandated by law that the patient had to have a first trimester ultrasound, a second trimester ultrasound, and a third trimester ultrasound, because they felt medically necessity. There was evidence to suggest those were 3 important time periods. We don't have a bunch of people from Germany or France or Italy who have all of a sudden major health issues, but they were exposed for those 3 time periods. But we also know that prudency tells us that we should expose the fetus to ultrasound for the least amount of time to get the most information. And we call that the ALARA principle, and that's the term that we use. Basically it says, get the most information you can in the least amount of time, so you just respect the fact that ultrasound is energy going into the body. And you don't expose the fetus to any more than you have to get the information. And that's where people make mistakes. If someone's scanning a patient for 45 minutes or 30 minutes, going back and forth and back and forth, they're not necessarily looking more carefully. They're probably trying to figure out, what am I seeing? And they're doing that live. You should be able to walk in, put the transducer on, look at the screen, know what's there, say, I know what this means, I know what this means, I know what this means, I get this and this and this. It's like a well-orchestrated approach. And you don't sit there wondering, well, I wonder what this is, I wonder what that is. That's what happens many times.
Thank you, Dr. DeVore. It was excellent explanation. We will be back shortly after a break. Thank you very much.
Dr. Sahag Arslanyan was born in Beirut, Lebanon, and he has been in the United States since 1966. He received his college education at the University of Hawaii in Bachelor of Arts in Chemistry with high honors, magna cum laude. At the University of Hawaii, he was selected in the National Honor Society of Phi Beta Kappa. Dr. Arslanyan received his medical degree from the prestigious Northwestern University Medical School, which is located in Chicago. He specialized in obstetrics and gynecology at St. Joseph Mercy Hospital in affiliation with University of Michigan in Ann Arbor, Michigan. His private office is located in Glendale. In the meantime, he teaches at UCLA as assistant clinical professor in obstetrics and gynecology. He sees his private patients in his Glendale office on Mondays, Wednesdays, and Fridays only. Dr. Sahag Arslanyan is the host and the executive producer of the medical TV show Medicine Today.
Hello again. Good having you with us. And I will continue my discussion with Dr. Gregory DeVore about prenatal diseases and tests. Dr. DeVore, let's discuss next topic, hypertension in pregnancy. So if you don't mind having the next picture, Dr. DeVore can address that issue. Go ahead. Here you see blood pressure is being taken, Dr. DeVore. The reason I'm showing this, tell me, which is the right way to take blood pressure? The right hand, left hand? Hand should be at the heart level. Why are you smiling? Because you will be surprised how sometimes patients take their own blood pressure.
I think this is an illustration of the proper way, where the arm is at the level you see it,
Okay.
and it's being taken by somebody else.
Okay.
There's, of course, the old way of taking blood pressure, which is what you see in this picture, or the automated approach.
Okay.
Also, you have to have the right size of cuff, depending on whether or not you are a larger or a smaller woman,
Yes.
so it fits. But I think for the most part, most obstetricians and most offices, nurses take blood pressure properly. And it's designed to pick up a disease that's very important for pregnant women to know that they have or not.
Right arm versus left arm makes difference
Does it?
because left arm is closer to the heart than the right.
Oh, I don't think that it makes a lot of difference. I think it depends on how you're set up. I mean, obviously, most of us are right-handed, so we give them the right arm. But I don't know that it makes a difference between right and
The
left.
difference between blood pressure from your point of view, your experience, this the old-fashioned way, the new-fashioned way, the automatic one you put over there, you just press it. What's your feeling about that?
Well, I think it depends what you buy and how good the device is. But if you go to, for example, intensive care units in the hospitals, they often have automated blood pressure devices. So it depends on the physician. You certainly have less what we call variance, or less fewer mistakes maybe in interpreting the blood pressure with the automated approach.
Yeah,
but this has been around for years, and we were all trained with this, and this is a very good tool to use.
Okay, next one, please. Okay, now it says diagnosis of hypertension in pregnancy gives you several things over there. You can look at it, and you can do your discussion, what you think about it. Okay, you want to go through that, then open, discuss it.
Well, let's talk about the two most common. Because there's been changes. As of November the 13th, the American College of Obstetricians and Gynecologists redefined the definitions of preeclampsia and hypertension. So let's talk about the two most common.
Let's come to the studio. Go ahead, Dr. DeVore.
Okay. The first type of high blood pressure in pregnancy is what's called chronic hypertension, meaning the patient before she became pregnant had hypertensive disease. So she would have been seen by an internist or a family practitioner, may or may not have been treated with medication, but she had hypertension before she became pregnant. Now, the reason that that's important to know about is because during the course of the pregnancy, the hypertension that she has, even though she's being treated, sometimes has association with other fetal conditions. For example, the baby, as it's growing, may not grow as big as it should, or the mother may have some complications from her hypertension. And the complication that we fear the most is what's called superimposed preeclampsia. Preeclampsia is a term that we use that consists of hypertension plus some other findings, but that can be superimposed upon the chronic hypertension and make, therefore, the disease much worse and have major complications for the mother. So we have to differentiate between the two as we care for the patient.
Now, let's take an example of a lady, which actually I have now, a lady who never had hypertension previous pregnancy, no hypertension at the present time, till when she's around 36, 37 weeks, noted diastolic of 1994, systolic 130, 140, which is no big deal, no proteinuria, no hyperreflexia, just little bit headache. So there's no component at the present time of pretoxemia. What do you think of that?
Okay, now let's translate that for the audience, okay?
Okay.
Proteinuria means protein in the urine. So our urine normally doesn't have much protein in it, but when you have preeclampsia, the protein can increase. We call that proteinuria. If we talk about blurred vision, meaning simply a patient who has preeclampsia in the severe form may all of a sudden see double or not see clearly because the preeclampsia is affecting the central nervous system. That's a very important sign. So patients can have different findings. The first finding, it's always present, for the most part, almost all the time, is the blood pressure rises above 140 systolic and above 90 diastolic.
Yes.
So that's the first clue. That's why we use those values. If the patient has that, then the physician, like yourself, will ask the question, are you going to show me more symptoms or more signs that make it more severe? Because if you go to the next level of severity with preeclampsia, then that can jeopardize the health of the mother and also of the child. And the only treatment for preeclampsia is delivery. There's no other treatment that's available. So you have to then, once you cross a certain threshold that you feel uncomfortable with, you then have to say, I'm not going any further. I have to deliver this baby because that's the treatment for this disease before it becomes even more severe.
Yeah, but you bring the patient to the hospital, they check her at the hospital. In general, it's fine. In general. There's once in a while 90 in the hospital with bed rest, no proteinuria, nothing else going on. And in the meantime, you don't like to deliver unless you have to because you may have a premature baby, breathing problems, so forth. So I was trying to find out.
What do you do? How do you manage it? Well, I'll tell you what we do.
Okay.
I also have an office. This is very interesting. I have an office in Lancaster that I just opened up about 5 months ago. Lancaster, we have a hospital that they do 6,000 deliveries a year there.
That's a lot.
A lot. And a lot of sick mothers because they come from areas that they don't have the same resources that we have down here. And we see a lot of disease, a lot of preeclampsia. And one of the things that we have found is that when a mother like you just described presents, one of the most important things you can do is look at the fetus. Because the fetus can tell you if the disease is going to be more severe than you think. Why? Because when the fetus is involved, and it's usually low fluid around the baby or poor growth, the fetal disease, the fetal component of preeclampsia that becomes significant is happening before the mother shows symptoms. So I can look at the fetus and say, you have growth problems, you have abnormal, what's called Doppler, you have abnormal fluids, you have a disease, your mom's going to show me even more symptoms very soon. So I use the fetus as a barometer to tell me how severe the mother may become.
Okay. Let's go, because we have so many things to discuss. Let's go to the next one, the pretoxemia or toxemia. Tell us what's pretoxemia, if you don't mind. Okay. I think we have next picture. Go ahead. Yeah, that's the one.
Okay, this is called toxemia. Is the term we've used for years. The term now that we use, that the patients, your viewers may see in the internet, is called preeclampsia. Now you'll notice there, for example, on that screen, it says hypertension taken or measured, or excuse me, the blood pressure is measured 6 hours apart on 2 occasions, greater than 140 over 90 for the blood pressure measurements, and proteinuria greater than 300 milligrams in 24-hour urine specimen. That was relevant up until mid-November, like I just mentioned a few
Yes.
minutes ago, because the American College of OB/GYN and others have said, we don't need to have proteinuria anymore to have the definition of preeclampsia.
I see.
They've thrown it out. It's not that it's not important, but they said you can have the same kinds of problems and complications without proteinuria with those findings than if you have it. So that's been removed from the criteria for
Good to know.
diagnosis.
Yeah.
So,
Okay,
so
let's
that,
come to the studio, please. Go ahead, Dr.
yeah, it just allows the clinician, like Dr. Arsalanian, to be more proactive when he simply has increased blood pressure that occurs after 32 weeks of the pregnancy, to be more aggressive.
Now, what causes pretoxemia or
We,
eclampsia?
we don't know all the answers, but we do know some associations. When we do a first trimester ultrasound, I measure what's called the umbilical artery Doppler resistance. And what it tells us, it's a tool that we have, that tells us if the measurement that I make is abnormal, that the vessels in the placenta early in the first trimester are not as large as they should be. Therefore, the blood going to the placenta has a harder time. I can recognize that and measure it. We know that if that is present and it persists throughout the second trimester, those patients have a higher risk for severe preeclampsia and complications. And we know that if we treat the mothers in the first trimester with baby aspirin, low-dose aspirin, 81 milligrams of aspirin per day, we can markedly decrease the incidence of preeclampsia. So we know there's a relationship.
Throughout the pregnancy?
Throughout
Or
the
you will not
pregnancy.
stop at 12?
We stop at 32 weeks.
32 weeks you stop.
But we
yeah.
give the aspirin, and what it causes is the platelets, that are the little things in the blood that stick to the walls when they want to clot. We decrease the stickiness of the platelets and change some other parameters so that the blood can flow through the placenta more efficiently and not trigger a cascade of events that lead to the disease of
What if
preeclampsia.
quite often there are two kinds of pretoxemia, early and late, and we see a late in pregnancy pretoxemia. Would then you give aspirin as well?
No,
Later in pregnancy?
Here's what we found. If we give aspirin, if we identify the patient in the first trimester, which we do with the
Yes.
Doppler that I mentioned, and we give the aspirin, then it has an effect and it decreases the incidence of severe preeclampsia and growth restriction. If we wait till later in pregnancy, in the second trimester, it doesn't have that much of an effect. So it has to be done in the first trimester. That's why the whole concept of nuchal translucency screening
Becomes
done with a
important.
Doppler of the uterine arteries in the first trimester
And why you
is
stop at
relevant.
32 weeks?
Oh, the reason for that is because after 32 weeks, there's the vessel called the ductus arteriosus in the fetus. It's a special vessel that keeps the blood going to the fetal, to the brain and other structures. And if the aspirin, it becomes more sensitive to the aspirin. So at 32 weeks or beyond, if you give aspirin, sometimes that vessel can close prematurely and create a problem. So we take it up through 32 weeks.
So why delivery will take care of the disease?
Don't know, but that's the way it goes. When you have that disease, when you deliver the mother, because you've removed the placenta, which I think is a trigger organ, you've removed all the hormones. There's a bunch of things going on in that pregnancy that causes this disease to manifest. You take that uterus and you remove the placenta, remove the fetus, and make the mother no longer pregnant, so to speak. Disease disappears. It's magic.
If you don't catch the pretoxemia, suppose you're not careful or whatever it is, or the patient doesn't follow the instructions, come to office next week, they don't come, whatever it is. And so it's not controlled, so we call it toxemia. What's toxemia? What happens?
Well,
or eclampsia?
Okay. Toxemia is a general term describing preeclampsia and eclampsia.
Yeah.
Eclampsia simply means the disease is so bad that the mother has a seizure. It affects her brain that she has a seizure. That's the most severe form of the disease process. So toxemia, think of it like a global term. Preeclampsia, you have all the symptoms, but you don't have a seizure. And eclampsia is when you have a seizure, and that seizure then really complicates the problem.
Complicates to the mother, to the baby, or both?
Well, primarily to the mother. The baby can survive the mother's seizure, but what happens when the mother has a seizure, that may cause severe problems, and it could lead to maternal death. That's, in fact, preeclampsia, other than hemorrhage, is the most common cause of maternal death in this country.
Okay. Now, next, let's go if we have a problem or even pretoxemia and so forth, or fetal growth retardation, this and that. We send patients for NST and AFI. So let's have the next pictures, please. Next pictures. Oh, this is another picture of the
Yeah,
toxemic.
that's a patient that has swelling that has preeclampsia or
Yeah.
toxemia.
Go ahead. Next one.
Okay. This happy woman lying in the chair,
Looking at you.
looking at me, has a belt across her abdomen. She's got two belts, one for recording the heart rate of the baby, one for recording contractions. This is called a non-stress test. The non-stress test is a printout of the heart rate over time, and you see little squiggles on the screen. I think you have a picture of
Yeah.
that.
Let's see the next picture, please. No, not
the
this.
next
Anyway,
one.
that's the. Go ahead,
Okay.
more. Go more.
That's the
Yeah.
one. Okay, that's the representation of the heart rate on the top, and that heart rate is going up and down, up and down. It's recording it over time. So the pattern that you see there gives us information about the well-being of the fetus at that moment in time. So we use this as a form of surveillance when we examine the mother and the fetus who has, for example, a history or the findings of preeclampsia.
This is the environment of the in utero, the environment for the baby.
Yes, how the fetus
yeah.
is doing inside compared
How
to
good, yeah.
yes.
Now, how long this is good? Is it good for 1 hour, 2 hours, 1 day,
Well,
2 days, 3 days?
Here's what we've learned. Statistically speaking, depending on the reason for the fetal problem, that if you have a normal non-stress test, it usually means the fetus is not going to die within the next 48 to 72 hours. However, you could have a very sick fetus that we see on ultrasound who has a normal non-stress test, that's what you see there, and can have things going on. That's why we use ultrasound coupled with this to look at the fetus at the same time.
Which we call AFI.
We call AFI is called the Amniotic Fluid Index, and we can look at the environment. We have a picture of that, I think,
Yeah, of
before. Go
course.
back
Let's
to
go-
the
go
previous
back.
image.
Let's see some pictures.
Right
That's
there.
the-
Okay, that's good. The fluid of the fetus. Now, in our practice, what I do, I go beyond that. I remember I said sometimes we do more than we get paid for. In our practice, we do the amniotic fluid measurement and the non-stress test, and we also do a computerized analysis of the heart rate tracing, which is very elegant and picks up clues that we can't see with the eye necessarily. And we also measure the blood flow to the fetal brain and blood flow to the cord. And when we add the blood flow to the cord, blood flow to the brain, the computerized analysis of the non-stress test and the fluid, we have a very comprehensive picture of what that fetus is like at that moment in time,
Yeah,
which is very good.
This is not, standardized in the community. How accurate it is?
Oh, the testing that what I just described
Yes.
is the most sophisticated, most accurate.
Okay,
And again, we always don't get paid for what we do.
but you will do it.
But I do it anyway,
Okay, good to
because
know.
that's what we do.
Now let's have the other picture, please. Next picture. This is another picture of AR. Explain that. What are black
Yes,
points there?
what you see there is you can probably recognize the foot. See the foot there in the middle of
Yes.
the picture. And then on top of that, the gray area is the placenta, and the black on left and right of the screen is the fluid. So we would look at that fluid and see whether it was enough or too little or too much.
Okay. Now let's come back to studio. In my practice, I have seen that when we follow in office, a lady, 36 weeks, 37, diabetes, we want to make sure that the baby's environment is okay. We do NST AFI. At times, NST is reactive, AFI is 4 or 5. We get scared. We send back to the hospital or repeat in the afternoon. Goes to the hospital, NST is okay, AFI now is 12. It has happened several times, not only in office setting, at the hospital setting. Like hospital admitted, observed, AFI is 6, and then in the morning AFI is 12. What happens? What's happening?
Well, it goes back to who's looking, okay? And here's what the problem is. There's two things that could happen.
Okay.
Certainly the fluid could increase from 5 to 12. We see that happen. But also it depends on who's doing the examination. I've been called sometimes, a physician like yourself might call and say, look, they said the AFI was 4, and I don't think it is, but that's what the hospital said. So I go in and the AFI is 14. So they misread it. The most common problem, however, is the following, is they think they read it out as a higher level, and it's really not. And the reason for that is because when you do the ultrasound assessment, around the fetus, there's two things. the amniotic fluid, the black that you saw on the screen, and the umbilical cord floating in the fluid. The umbilical cord in the fluid can have the same appearance, black, as the fluid. So some people can make the mistake, say, oh, I have lots of fluid here.
But it's
And in
umbilical
reality,
cord.
it's umbilical cord coiled up. So you have to use what's called color Doppler to light up the cord and make sure you don't have cord, you simply have fluid. If you do that, then you'll have fewer mistakes as far as measuring the amount of fluid that's present.
But the uterus is three-dimensional, right?
Yes.
So you can get fluid from here, you can get from the side, but you can't get from the back. What
Well-
if there was fluid in the back?
Well, not quite true.
Okay.
What you're really, I think, saying is that when we make a measurement, we call it the amniotic fluid index, we only measure straight down.
Yes,
It's called the depth. We don't measure the width, we don't measure the depth.
yes.
We kind of do that when we go to different areas in the uterus. So when the person is measuring the fluid, you have to have experienced, when you put the probe on and say, you know, I may have a number, but that fluid is very little, it's very narrow, it's not as big as I would expect. So you have to have, there's a subjective component to interpreting what you're doing. That's why you have to know what you're doing to do it, and not just get a number. And so this happens a lot where people don't have the experience to understand what they're saying.
What makes amniotic fluid? It's what? What it is? Baby's urine or what?
Yes, it is. We tell patients, we call it amniotic fluid. It's really fetal urine. They're swimming in their urine, but that sounds kind of disgusting when you tell people that, so you call it amniotic fluid, but that's really what it is. And the fetus swallows it, and it urinates, so it's a cycle. Swallow, urinate. There's a balance between the two. And if you don't swallow enough, you have extra fluid that builds up. If you swallow normally but don't make it, then you have low fluid.
So
it
low
just-
fluid is bad news.
It's
in
bad
it
news.
Because
low fluid can do two things. It represents primarily a placental problem, a bad placenta. It also can create a situation where the cord now is so tight in there that the kid kicks the cord and there's no room for the cord to bounce away, and they can get compressed and cause a cord accident or a cord problem.
we got 1 minute 40 seconds. Let's have the last picture for Dr. DeVore. Last picture where it's about iPhone. No, not the iPhone.
That's the one. That's the picture. But
That's a picture. Okay.
we have to just put it on
show
the
the
screen.
picture, Steve.
there you
Yeah,
go.
go ahead.
This is the latest technology. And what it is, it serves two purposes, really. Patients always come and they ask, can I have a picture of my baby? And then we'd give them a hard copy picture or a color picture. It's the newest technology that we have, and we work with a company that's developed this. I can send the pictures from my machine to your iPhone within a minute. So I take a bunch of pictures. I said, which ones did you like? Click, 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 click. Hit a button, goes to the sky, comes back to their phone in a minute, and then they download the pictures on their phone. They can share it with their family. Well, I use this, for example, when I have cardiac findings and I want to talk to my colleagues who are cardiologists. I can send them the clips and the images, and it works very
How
well.
much you charge?
Nothing for it. It's free.
Nice man. I've
Free.
always okay. Thank you, Dr. DeVore. Thank you to you for being with us today. It was a very nice educational interview with you, Dr. DeVore, about prenatal screening, and also thank you for the studio, which they have done a good job today. Thanks a lot.